Okay. Good morning, everyone, and welcome to the Insurance and Pharmaceuticals Subcommittee of the Health and Government Operations Committee. We are meeting today to discuss House Bill 585, which addresses medical debt in the state. We began discussing this bill on Tuesday, or Monday rather, and we're going to continue through the process. We're going to start where we left off on Monday, continue through the process of going through the bill page by page. We're going to begin on page 7. And what I'd ask is that you concisely identify your concern, if there's a concern about language that's here in the reprint. I'd also ask that if someone else has voiced your concern, that you say, me too, on X. We have a limited amount of time, and my goal, if we can accomplish this, is, although we may have to do one more session tomorrow and then look at a final product on Monday. We are bumping up now against crossover, so we really need to get this, if we're to get this moving in order to get it over to the Senate in time for their action. So that's our process for today. We are meeting again tomorrow. We will take the feedback that was given on Monday and then today, see where we can work out some language that might meet some needs and interests and concerns, and then come back to you tomorrow with that. But I would really like to finish the bill today. Finished going through it today. Delegate Carr sent a list of questions to the whole group. I wanted the chance to respond to the questions to the whole group since they were sent out. I just have to find it, and I beg your indulgence because my laptop died last night, and so I'm on a loaner, so I'm using something that doesn't have everything I need on it, but we're going to make do. So,
Madam Chairman, sorry to interrupt.
Oh, sorry.
Could Aaron or somebody email me the reprint? I'm sure you already emailed it, but I'm frantically trying to find it.
Okay. Is there anyone else who needs the reprint?
Did that, Delegate Kipke?
Okay. And is Delegate Charkoudian in the room?
Yes.
Okay, good, because I just saw a message that she needed the link. So
I'm here. I apologize. I am single parenting with none of the usual childcare things in place because of the pandemic. So I'm driving right now, and my apologies, but I know the bill and I can comment if needed. Okay,
thank you, Delegate. I appreciate that. Appreciate you being here. I know it's tough with all those other responsibilities. Okay, so Delegate Carr's question, the first question was with respect to getting 2 bills, one for what seems to be the hospital and one for Bethesda Emergency Associates, which is likely the physician, saying that his insurance pays, his ER copay is $150. And does this bill address both of those bills? So this bill addresses whatever the cost of the visit to the ER are. But it doesn't address the insurance issue. So each insurance product has its own elements around what that $150 covers. It could just cover the hospital part. It could just cover the physician part. And that's something that you really have to work out and understand from your carrier. So for the purposes of this bill, we're really talking about what the cost of the medical service at the hospital is. The second one.
Can I speak to that, Madam Chair?
Sure.
So in my experience, you visit a hospital and you might get 1 bill back for your visit, or you might get 2. And that depends on whether your claim got messed up or not. If your claim doesn't get messed up, it gets processed the way it's supposed to, you get one bill and it's from the hospital. If something goes wrong, you end up getting two bills. So just the question was, I mean, it sounds like this legislation is only covering the hospital bill and not other bills that you might get resulting from a hospital visit. Is that correct?
This bill is addressing the hospital charges.
Okay, not
Right. And again, I would advise you to work with your insurance carrier, because when you're discussing the claim issue, that's with the carrier. Not the hospital is.
well, but they're intertwined. They're intertwined. You can't separate it so easily.
I understand, but there's an issue and a part with the claims. The way it's processed is going to be in the carrier's domain. I'm going to skip your second question because that's on page 7, which is relating to the need for formal notification of an appeals process. And question number 3, question number 3 again relates to issues with the carriers. And what this bill says is if there is an appeal in process, then no action can be taken. So as long as the hospital knows that the appeal is in process, if there's difficulty with the appeal, whether it's through the carrier or through the Attorney General's office or through the Maryland Insurance Administration, as long as the hospital knows there is an appeal in process, no action will be taken. That's what this bill says. And so again, if the claim is a problem, then that has to go through the carrier.
May I speak to that, Madam Chair?
Sure.
So really the hospital is a part of the appeal process. I mean, number one, it's difficult to find out where the claim went awry. The hospital is sending in the claim, and if you can't see what the hospital sent to the carrier, it's hard to figure out what went wrong, and then the burden is on the patient to fix it. And you can't fix your claim without getting access to the records, and those come from the hospital. It's difficult to get the records from the hospital. It can be a manual process, a paper-intensive process. It can take a long time. And this is because of the policies of the hospital. So it's not just the carrier and the other parties. And my question really is, what are the hospitals doing to improve a process that hinders the appeal and that is problematic?
Can you be more explicit about the way that the hospital's hindering the process?
Right. So let's say you visit a hospital.
Mm-hmm.
They send in the claim to your carrier, get an explanation of benefits back. We processed your claim, and you think, well, my coverage is, my copay is $150 for an ER visit, but the claim is being processed differently, and you're being told you have to pay $600 because from the claim, we can't verify that this was a legitimate ER visit. You have the right to appeal. In order to appeal, you have to provide us with the ER record. You get the record of all the paperwork of enclosed in your visit, and that is in the possession of the hospital. So you have to go to the hospital, obtain all those records, send them to the carrier, and that is a difficult and time-consuming process to obtain that record because of the policies of the hospital.
Okay, then I am going to ask Jennifer Whitten to help us understand why it works that way.
Thanks, Delegate Colson. I'm actually going to ask my colleague Mansi to respond. This
Okay.
is an important, I think, clarification for the committee.
Thank you.
Thanks, Jen, and thank you, Delegate Colson. Thank you, Delegate Carr, for raising the question. I think there's some confusion, which might be the best word, in terms of what is the ability for a hospital to be able to engage in an appeals process that is really set out by the carrier, the insurance carrier. If there are questions about what is covered within an insurance plan, what any out-of-pocket cost covers, I mean, that really solely resides in the insurance carrier's discretion. That is not something that the hospital can address. And so when services are rendered at a hospital or any other healthcare provider for that matter, there are some components that are covered by the insurance carrier and others that are not. And, once you have the claims processing or the appeals piece that you're going through, again, providers don't set out the types of information that's required for insurance carriers to actually go through that appeal. The insurance carrier sets out those requirements of what they need in terms of the documentation. On the other end, there's a plethora of federal and state laws in terms of documentations that healthcare providers need to keep. And so hopefully you can appreciate that that is all being shared in the interest of sharing with patients whatever they need for purposes of the appeal. But again, I would say that both the way in which an appeal is filed, what is covered under an insurance plan, and the requirements that are a part of that appeal are all set out by the insurance carrier.
Yeah, I guess with all due respect, I think you're missing the point of that question. So this specific question is specifically about the policies of the hospital. When the appeal of a claim involves getting information from the hospital, which it frequently does, and which is made difficult because of the policies of the hospital, I think there needs to be a better response from you about acknowledging this problem that it exists, because it does exist and it affects real people. And what are you doing to make this easier for patients?
Delegate Carr, I appreciate that point. We also understand that, the patient is having to navigate that insurer appeals process, and it can be difficult. I would say to you that we welcome, direct communication from the insurance carrier to really be able to work on that appeals process with them and understand what they need.
Yeah, no, this is, again, I'm talking about the hospital, the experience after the care when you're trying to get your records from the hospital so that you can fix the claim. Of course, I understand, that the insurer determines the policy, but on this specific piece of the process involves the hospital, and it's the policies of the hospital. The sign when you come into that office, warning you of, that you're going to get charged per page to see your records, and the fact that the process is very manual, very labor intensive, very time consuming. That is an issue with the hospital, not with the carrier.
So if I'm understanding, Delegate, you're really speaking to the process by which hospitals provide records to the patient in their grievance process with the carrier.
Correct. In order to appeal your
I
insurance
understand.
claim,
We understand, Delegate. I'm sorry to cut you.
Relying on the hospital to get
Delegate,
a copy of their records.
So I think we have the idea. I'm going to ask that the hospitals that we look at what the process is now in terms of, and if it's uniform across hospitals. We don't have to discuss that now, but let's know tomorrow whether or not how that process is set up so that it can be as facilitated as possible and still meet the legal requirements of laws, et cetera. Okay, so then the last question was that apparently in Delegate Carr's experience, he was told that there was an internal lawsuit threshold And why can't these be more transparent? Why can't people know them? Right now, these decisions are all made independently by individual hospitals. What this bill does is try to bring some uniformity into that process. So I think, we're trying to address that issue with this bill. And so I'm hoping that we can do that. So those are Delegate Carr's questions, and I'd want to start with page 7. And as I said, Delegate Carr asked about the lines 16 to 22, how the hospitals would envision that happening in terms of the formal notification of a grievance process. I'm going to look to the hospitals to talk to us about what they need there, or what would make it easier for them to know that there is a pending appeal. Do you want to start, or?
Sure, Delegate Collison, and my apologies, I may have missed just the top of your comments, but I think the comments are, what would be helpful for hospitals in terms of knowing that an individual is going through a formal appeals process or grievance process. I think we also have the Maryland Insurance Administration, who has oversight in this space as well. I think just to circle back to Monsi's point is that it's really the insurance carriers that are making the determination on what they're covering. And currently, insurance carriers do not notify hospitals when they are going through that process. So, we would agree that some sort of a notification or improved process and communication would be helpful. Right now, the onus is on the patient, and we understand that that can be really complex and challenging. So I know this bill seeks to at least try to attempt in improving some of that process. However, it still really, I think, puts the requirement mostly on the patients, but we are open to working, with the carriers on improving that. But those determinations, again, unfortunately, are made by the insurance carriers. And so hospitals can respond once that information is shared, either by the carriers or by the Maryland Insurance Administration, as they have oversight of this process as well, if there's a grievance filed.
So is
Madam
the
Chair?
Delegate Carr?
So yeah, thank you, Jennifer. You didn't really answer the question. So the question really is, how do you envision that process? If I'm a patient and the law says that I can notify you, the hospital, that I've appealed my claim, how do you envision that happening? You go to the hospital, for your visit. Your claim gets handled. You get an explanation of benefits. The patient has a portion that they're required to pay according to the claim. You get an invoice in the mail from the hospital. Please pay X amount of dollars. You can mail your check in the envelope that we included. You can write your credit card down. You can go online and pay it. How do you anticipate that notification taking place? Is it in writing? Is it verbal? Is there a checkoff on that response sheet? How do you envision that happening? And what happens if there's a dispute where the patient says, I notified you, the hospital says, I don't have a record of you notifying me. Can you please elaborate on how you envision that notification taking place?
Delegate Carr, so just to clarify, and I think you're speaking to some of the provisions that are later in the bill, and so we'll let the chair decide how she wants to proceed forward with that. But again,
I'm speaking to page 7, line 16 to 22, where
Correct.
it says, if the hospital was notified of a formal appeal. That's specifically what I'm talking to, the page that we're on.
So if the hospital is notified by that there's a formal appeal, again, either by the patient or by the insurance carrier.
How does the patient notify the hospital that there's an appeal?
Then
how do
That's
you
a good
envision that
question.
happening? Verbally, in writing, how do you envision that happening?
So Delegate, I'd be happy to answer that question. We will have to develop that process in terms of implementation. Once we work with the agency on the regulations and the process, it will be a new clinic flow. It will be a new notification process. As you know, many notifications come out after the first initial bill. So we will have to work that into the extension of all the additional notifications. And again, this is part of the collection process. This is after the first initial bill was established and follow-up financial statements and billing statements. So yes, we're going to have to work through that process to ensure we've got the right notification. But again, we'll have to make sure we have that information to make that determination.
So Jen, I'm going to just say, basically, what you're going to do is develop the process by which there is some sort of written notification of a formal appeals process. I mean, that's basically,
I'm just
Delegate, what I would say
wondering
is that,
if in the bill, we need to be a little more specific about how that happens. Because if the answer is, we'll figure it out later, I think we're possibly setting ourselves up for problems.
okay, you've identified the issue, Delegate. Thank you. I'm going to go to Monzi. Did you want to speak to that issue specifically or something else?
It was to this issue specifically, Delegate.
Okay.
Largely me too with Jen, obviously, but the other part of this is new language, Delegate, with all due respect, in the bill. And so we are working through this session and needing to think about, again, how we would address the workflow issues in this space. But I can tell you that, in working through this over the past few weeks, we are trying to understand at the macro level the significant reforms that this bill includes and how we would have to change those workflows. So we have not, been able to get to that place of thinking about this component in particular and what those workflow changes would need to look like. Would appreciate that we are continuously trying to strike the balance of enhancing some protections, if I can use the right words here, in this space, but at the same time need to make sure that where we are with this bill is feasible to actually implement.
Yeah. Thank you. I'm going to go to Delegate Morgan.
Thank you, Madam Chair. Just want to make sure I understand the issue. So yeah, patient walks in the hospital provides the service, hospital bills the insurance company. At that point, the bill is at the insurance company. The hospital doesn't have any control when that bill is actually processed or paid, correct?
Correct.
Okay.
And anything that's not paid by the insurance is then billed to the patient.
But the hospital has no control of when that occurs?
Correct.
Period.
Right.
Okay.
Now, the hospitals have rules around, the carriers have rules around how fast they're supposed to process claims. But, as Delegate Carr says, sometimes things don't happen as easily as we would like them.
So even if you had a repeal process,
Appeal, yeah.
you have to reprint all the 60-day within 60 days. That's a pretty quick amount of time considering the bill was probably pushed off. You have no idea how long it's been pushed off, correct?
Well, it would be 60 days after the patient was notified that they owe money.
Okay, gotcha. But it could be
Right.
months, right? Since the date of service.
Could be, yes.
Okay. Because I'm just concerned about uncompensated care at some point.
Yeah. Pat O'Connor. Thank you, Delegate. Pat O'Connor?
Yes, Pat O'Connor, Health Education Advocacy Unit in the Attorney General's office. It is our unit that assists consumers in Maryland with appeals to the MIA relating to state regulated plans. We do what we can also for the many Marylanders who are not enrolled in state regulated plans. It's important to understand that patients have little to no control over the time that is taken by these large institutional actors. In light of that, when we were working with the sponsor on the language relating to what would be the balance between the patient and the hospital regarding making sure the hospital knows about insurance appeals, either through the Maryland Insurance Administration or in the non-state regulated plans through the Department of Labor. We asked for the word informed, and we would prefer the use of that word. We don't think that creating a formal notification, as this replacement language suggests, is necessarily consistent with the spirit of the federal regulations that were enacted as part of the Affordable Care Act. And what we are doing here in this bill is supposed to be in keeping with or in conformity with that. And the concept throughout the federal regulations, which require the hospitals to comply with these, impose these requirements so the hospitals maintain their tax exempt status, is that reasonableness control. And we are concerned that creating a formal notification is not reasonable under the typical circumstances based on our experience assisting consumers with these appeals. And to the points that everyone is making, the appeals often involve multiple requests back and forth for records and then time periods. And while there are state provisions that attempt to control the timeline, there are a lot of exceptions. This is a really important point for consumers because they pay so much for their insurance. And there are, in our annual reports, we document, and I believe it was up to 52% of the claims submitted in state regulated plans get denied. We assist with those appeals. And this is really, really important so that patients don't get their adverse reports or lawsuits filed when they've done what they can and the system is not assisting them.
So Pat, I'm going to ask, so this language on line 20 is saying it says it's a formal, that the hospital is notified / informed of a formal appeals process, which means that the individual has actually engaged with either the carrier, your office, or MIA. That's the formal part. So what we're hearing now is, whether or not this information, the informed part or the notified part, has to be in writing, or how that happens, and that's something we will take into consideration as we.
Right, and I would submit there is no appeal that is not formal. An appeal is an appeal, and so inserting that word, we worry, would allow wiggle room that is not in keeping with the reasonableness requirement for consumers. And also, I mean, there are many ways, if the hospital is genuinely engaging with the consumer in an effort to pay the bill, this information can be shared in a phone call and an email, and that should suffice.
Okay. Like I said, we're taking these under advisement and working on it tonight, probably. Okay, anything else on page 7? Wait a minute, we've got Delegate Charkoudian.
Thank you, Madam Chair. Yeah, I'm just wondering if we can talk a little bit more about the removal of delegating the collection activity to a debt collector, because I think sort of the idea behind this section, and then also later when it talks about the affidavits and so on, is that basically you don't want anything that could sort of harm a consumer's, I'm sorry, the other section on payment plans. You don't want anything that could be harmful to a consumer's credit, to their records, to, all the stuff that's difficult to dig out of, once you prove that you were eligible for free reduced cost care, or you get your, payment plan taken care of, or what have you. And so removing that it can't be turned over to a debt collector is concerning to me. And I guess maybe it would be helpful, because in my brief conversation with you, Madam Chair, about this, and it sounded like the debt collectors, maybe we have different ideas about what a debt collector is. My understanding of what a debt collector is, having had things erroneously put into collections of my own accounts, is it's a pretty aggressive difficult process. It's not someone calling and saying, can we work with you to establish a payment plan? So I just want to understand like who falls under the definition of debt collector, and just trying to make sure that we're on the same page on this idea of we're trying to give consumers a chance to get their appeals done, get their payment plan, work through the paperwork, whatever it is that needs to be done before essentially bad things start to happen to them. And so maybe we just need to understand debt collectors better, but my understanding of what a debt collector is, it's kind of in the category of bad things start to happen.
Okay, Jennifer, who's best on your team to respond to that?
I can respond, Delegate Colson. This is Monse.
Okay, Monse. Mhm.
Thank you, Delegate Charkoudian. We have, I think, throughout this process, just shared that, and some of the members of the subcommittee might recall the briefing that we had back in November. We had shared that there are agencies that work with hospitals and on essentially as extenders of staff, if you will, to help with that financial assistance screening process and really engaging the individual in trying to get them eligible for financial assistance and put them on payment plans before they would actually get to the collection component. And so when we have this language here around debt collectors, we are removing the ability for the hospital to go work with those agencies to try to capture individuals in the financial assistance process and or get them on insurance coverage or get them on payment plans. And so I can appreciate that that is your understanding of it, but really the debt collection agency does not do payment collections. It does a whole host of other things that we really need to have the ability for them to continue to be able to do. It's not something that the hospitals can continue to just be able to do in-house. So that's an important point as to why that language needs to, we appreciate that language sort of looking as it is right now.
Okay, Delegate Saab.
Thank you, Madam Chairman. I just have, I guess it's a timeline question. So usually hospitals or providers have to submit their claims within 90 days, otherwise they don't get paid. So the date of service is, let's say today, within 90 days, they have to submit the bill, and then you have another 60 days for the bill to go out. I guess my question is, what's the timeline before any of that stuff goes to collections, and how many attempts? Because obviously when you go to collection, you lose because you never get the whole amount. Sometimes the collection companies, they settle and it's costly. So I believe every provider has the incentive to try to settle before that. So I guess my question is, how long is the timeline before this whole thing happened when you have like an average bill getting paid? Maybe Jennifer can answer that.
Jennifer?
Yeah, thank you, Delegate Saab, for the question. So kind of talking through some of the sequence. So after the first initial bill is sent, then there are essentially 4 to 5 billing statements that are sent to the patient, typically within 1 month intervals. And so that individual will receive, a number of bills at roughly around the 90 mark day. That is when, based on federal law, that hospitals can then begin to actually collect on the debt owed. And so this is after several statements and opportunities for financial assistance. Hospitals cannot take any additional collection activity until 120 days or post 120 days. So in essence, an individual would have an opportunity up to 120 days to work with the hospitals on financial assistance. However, they also have up to 240 days, which is part of the financial assistance law. And also within this bill here to, again, continue to work on financial assistance to see if they in fact do screen for Medicaid eligibility or other free or reduced care. So it's a pretty extensive process. And then with this bill, again, we'd be adding additional notifications. So hopefully that helps address
Yeah,
that.
so that's about almost 2 years from the date of service, right? Because you got the 3 months plus the 6 attempts, which is 6 months, plus the 120 days. So you're almost in 2 years before you go to collection, correct?
I don't know. No, I wouldn't say that it's 2 years, but we're definitely hitting sort of a year mark.
Yeah,
Okay.
it's about a year.
Thank you, Madam Chairman.
Thank you, Delegate. Marceline White?
Thank you, Delegate. This is a me too on Delegate Charkoudian's point about debt collection. Just to make the point that you have testimony in the file from a Miss Esposito, for example, who was pursued by debt collection in a much quicker timeline than has been laid out by MHA and from the legal service providers we work with. What is stated in the guidelines and what seems to be happening are very different experiences. So I have someone who wrote to me who was pursued by Johns Hopkins for a $20 bill, so I think, and pursued by the collections. So I do believe that the process that has been laid out may be very adequate, but what seems to be happening, there's a real disconnect, which I think, again, we see from the HSCRC report in terms of the number of people who are pursued for bad debt that should have gotten free care. So I just think we don't want anybody to have adverse reporting on their credit. And, I'd appreciate, again, having this committee revisit the original language around the debt collection. I'll leave it at that. Thank you.
Thank you. Delegate Kipke?
Thank you, Madam Chairman. My question is to, I guess, MHA. I mean, obviously, nobody wants it to go to collections because there's a reduced recovery. So it's costly to the system to do that. So I'm curious, though, is it successful? Is that successful? Is there a great amount of recovery by going to collections? I mean, obviously, it was just mentioned somebody was sent to collections for $20. I don't think there's anything wrong with that. If somebody owes the money, they should pay it. And if you take $20 times 10,000 situations, that adds up. And if they don't pay it, everybody else pays it. So I'm just curious, is it successful when you go to collections? And if you can speak to that. And then the second question is, for the vulnerable that we're all concerned about, during the repeated attempts to collect initially, what notification is made, and is it universal regarding one's inability to pay to seek alternative remedy like a payment plan?
Jen, who on your team?
So Delegate Carr, this is Brett McCone. Thank you very much, and I'll speak to that. Delegate Kipke, thank you for your question. So, there is a process here in place. When the first bill goes out, that's typically 30 days after the service. On every bill, as required by state law, we have to send the patient what's called the information sheet. And in the information sheet, there's information about how to obtain financial assistance, who to contact at the hospital if you need financial assistance. So typically, again, first bill goes out 30 days. Every bill subsequent to that, like we said, on a monthly basis, has that information sheet, has that that process there.
Hey, Brett,
and the patient, I'm sorry.
Could you send that to us? Like, give us an example from maybe a couple of systems, just so that we can see what that looks like.
Absolutely, and that's required by state law for every hospital. So at any time, looking at that bill, there is information on there for the patient to contact the hospital to address that. So at that time, typically, if there's non-payment, the hospital will make multiple attempts to try and contact the patient. If they are in the electronic system, they'll have notifications or emails. We also work with, again, outside vendor partners that typically are doing outreach, one, to try and contact the patient to see if they are eligible for financial assistance, or more importantly, to get them eligible for medical assistance for Medicaid if they qualify. So typically that's the first step in the process, is to go through that whole screening process. At the time, then the patient would fill out the financial assistance application or give the other information to try and get them qualified for Medicaid. During that process, we always check publicly available information to see if their patient is otherwise eligible for governmental assistance programs. And then typically, if we know that, then we call it early out. We early out the patient to charity care, and we write that off. What happens then if there's no response, or we don't have any way of knowing that the patient is seeking financial assistance, again, after multiple statements with the information, then we would typically, the collection agencies would contact the patient to try and pursue collections. At any time, if the patient notifies the hospital that they're not in a position to pay, we are more than happy to set up payment plans with any patient. But there's a multi-step process. We cannot delegate by state law. We cannot delegate collection activity until at least 120 days after the encounter. And the bill, as the language in there, would extend that to 180 days. And we are fine with that for additional notification. The patient also has up to 240 days to seek financial assistance as well. When we do go to collection, again, typically we don't collect 100% of that, nor do we expect to. But we work through that process after multiple notifications.
Is it successful, the collections part of it? I mean, I personally know people who have had collections for hospital bills, and I personally know they could pay them. And, we don't want a system where people are just not going to pay and the rest of us have to pay. So, what ultimately, what is the success rate?
So the success rate, it depends on the individual. In some cases, after contact and they realize they've missed it, you will get 100% payment from those things, particularly on some of the smaller bills. When it goes all the way through to collection, though, on average, we might, if the patient goes to a payment plan, we might get anywhere between 10 and 50%. It just depends on the patient's situation. And that's why we try to meet the patient where they are, why we're doing the collection process, and the fact that, we want to avoid the bad debt if we can. But that's why we go through the collection process and have the multiple notifications.
Thank you.
Thank you. Delegate Lewis-Young.
Thank you, Madam Chair. This whole conversation about debt collection is reminding me why I feel very strongly about restoring the phraseology about not only patients who qualify for free care, but also reduced care into the language. I used to work developing credit policy. And the way we made credit decisions, we looked at a variety of factors. I won't go through all of them, but how many times you were late, 30 days or over was a criteria. Did you ever go to collections was a criteria. And of course, the more your scores went up on those criteria, the harder it became to borrow. And if you could borrow, you had to borrow at a higher rate. So what happened then, people with bad credit ratings would have to borrow at a higher rate. They couldn't pay it. And then in industry language, they went belly up. So it's a snowballing effect. And many companies today still will not hire you without a credit report. So if something happened in your past and it was a mistake or you were going through a rough time, you can't get a job. So we need to not only pay attention to this particular situation, but the long-term consequences of hurting someone's credit report. And I want to respond to Delegate Kipke's question because I actually did some research about national debt collection, and I understand it differs industry by industry, but on a national basis for debt under $1,000, between 40 and 50% is actually collected. Between $1,000 and $5,000, 20 to 30% is collected.
Well, that's a whole lot better than zero. And if they don't pay it, everybody else pays it.
Right.
People who will evade paying if you don't have it.
I would point out, Delegate Lewis Young, that on line 14, we do include reduced care in this section. And we also include it again down below in line 33. So there is consideration of reduced care in this section of the reprint.
But as I said in our last meeting, I think we
Reduce
need to
cost.
make that consistent.
I've got Marceline.
Sorry, I actually did not. I meant to take
Oh.
my hand down. I
Okay,
apologize.
thanks. Okay. Anything else on page 7? Not that we've stayed on page 7, but is there anything here that, okay, we're going to move to page 8. Questions, concerns on page 8. Delegate Lewis Young.
Thank you for allowing me up to the bat twice in a row. One of my biggest concerns is removing on page 8 lines 21 and 22. I think we need to restore that threshold of $1,000. And it's for many of the reasons that I just mentioned, not only because there are so many vulnerable people that this will affect, but quite frankly, I think it's a bad business decision not to have a threshold. And I want to give a quick example. When I was at American Express, now granted it was a long time ago, any amount in dispute for $50 or less, we just wrote off. It wasn't worth our research time to look at the dispute. And that doesn't include recovery or legal costs. That's just research costs. So that was 40 years ago. In today's dollars, that would be about $150. So I'm not sure why make the investment from a business perspective. And by the way, we didn't publicize that. And it was rarely abused. And if it was, we didn't do it anymore. And given the stats that I just gave about how little the percentage that you actually collect, I think from a business perspective, it makes sense to have a non-published threshold.
But Delegate, if we put it in the bill, wouldn't it be published?
How many it would be published, but how many, I mean, the hospital wouldn't post it in its Bill of Rights that are posted visibly in the lobbies.
Okay.
Consumers are not going to know.
Right. I've got Marceline.
Hi, thank you, Delegate. Just to expand on what Delegate Lewis Young said, and I think I'm actually agreeing with some of what Delegate Kipke said. I think we need to restore the threshold on lawsuits, in part because, as already discussed by MHA, 10 to 50% of the medical debt is already recouped through debt collection activity. And I do not believe that a lawsuit is necessary in order to recoup the medical debt. That's why we called for the income-based repayment plans, so people who don't have $2,000 in one fell swoop can pay the debt off. We agree the hospital should be paid. That's why we want an installment payment plan so they can pay it off in a way that is manageable over time, and the hospital does get paid. And that's why we are not saying you cannot collect on the debt. We just don't think you should be sued on it, because once you are sued on the debt, you also have attorney's fees and interest rates. And that's where some of the most onerous consequences come in, where you have things like a lien on the home or wage garnishment, also bank garnishments. And so we think that the system in place, including both the payment plan and including debt collection activity as shown, does recoup up to 50% of the cost. The BU Economist study showed this would only, if you cap the threshold, this would only cost on average $7,000 per hospital. And it would also save the court the cost of administering and dealing with these kinds of issues when the courts are already overwhelmed. And also would save the hospital from having to deal with, going through the court system as well, if they could handle it through these other two issues, these other two ways. So we would urge that this be reinstated. Thank you.
Thank you. Delegate Kipke.
Thank you, Madam Chairman. And very respectfully to the prior speakers, I very strongly disagree. A payment plan is completely useless if there's no teeth in living up to your obligations in the payment plan. And I personally know of scores of people who have had actions taken to court because of unpaid hospital bills, and they paid them. And the bottom line is we've expanded Medicaid. I voted for it. It was very controversial for me to vote for expansion of Medicaid, but I voted for it because, I think that it was the right decision. We have an individual health insurance market that's healthy and with great large subsidies for folks. So, I just don't think there's an excuse here to eliminate the ability for nonprofit systems to have a hammer to make sure people pay the bills that they can afford to pay and are choosing to evade. So, and at the end of the day, if you don't get the money from these people, everybody else is going to have to pay for it, which means health insurance rates go up for everybody else. We had that problem in this state where it was really becoming, and we have to be very careful not to put in place incentives for people just to evade their bills, because it's going to raise health insurance rates in the state, which we just can't allow to happen. Thank you.
Okay, so I've got like 4 hands that I think are referring to this issue. I would like to take those 4 hands and then and hear both sides, but I would ask that you keep your remarks as brief as possible. You've heard the arguments of the folks before you. We have approximately 15 more minutes today before we need to get ready to go to the floor. So that's why I'd like to, move us a little bit farther if we can get there. Delegate Carr.
Thank you, Madam Chair. As I've mentioned before, my wife got sued by Hopkins for the amount of $75. And it wasn't because she was trying to evade paying. It's not that she wasn't going to pay or she couldn't pay. There was a dispute, involving the claim, and the hospital was a part of that. It's not all on the carrier. The hospital is equally in the blame for that. But what was revealed to me was that, at least in the case of Hopkins, the hospitals, they have internal limits below which they will not sue. I was told that the limit was raised at Hopkins to $300. So, if my wife incurred a similar debt in the future, she wouldn't have been sued for that. So given the fact that the hospitals already have these internal limits, so they're already doing this, this policy that could possibly be in this law, why not just make it consistent across Maryland, where we have a limit and it's transparent, it's consistent, not that the hospitals have to publish it in their Bill of Rights, but I think that would be a good policy to reinstate a threshold.
Going to Delegate Saab.
Thank you, Madam Chairman. So I guess my question is, well, I got 2 comments. When you go to the hospital, they don't always take your social security number. So I just have some clarification on, if they don't have your social, they can't really put on your credit unless if they have your social. But to Delegate Carr's point is, if you change the threshold and you report on the threshold, that would change the individual's behavior. And if I know you're not going to sue me if I owe $75 or $100, whatever it is, I'm not going to pay it. So I don't think we want to change consumers' behavior, because that's going to result in much higher unpaid bills. So how do we find a middle ground for the people that really can't afford to pay it versus the people that just don't want to pay it because they disagree with the bill.
And that's really what we're trying to do with this bill, Delegate. Thank you for pointing that out. This bill is about creating a system where we can make sure we identify those who have the financial need and those who can pay back over time at a rate that's not a financial burden to them.
And then, Chairman, just like one last thing, and I know this is just more on the bill than itself, but I mean, the hospitals are in the business to provide health service, not to really collect. So I just also don't want to put too much onerous on them that they have to come up with, policies that's going to hurt the ability to provide the health service.
Okay, thank you, Delegate. Amy Hennon.
Thank you, Delegate Cullison. I would like to respectfully disagree with the comments that if folks are not sued, that there would be some sort of incentive in the system that would prevent them from repaying. These are the clients that I work with every single day, that my organization serves, and most of these folks are, when they are receiving calls and letters, there are a variety of incentives for them to pay. They find the calls and letters, in fact, very stressful, very threatening, and in fact, potential impact on credit is one of the biggest concerns of most of my clients. It's less a concern about lawsuits. I actually work with a lot of clients who are in fact older adults who have non-collectible income, meaning that their Social Security is protected from garnishment, and they still want to repay the debts that they owe, and it doesn't have to do with the fact that because they feel an obligation. And so I definitely disagree that there are folks that this is going to create some sort of perverse incentive in the system that people are not going to want to repay. And so the one other thing that I want to say about that is just that it's not that people don't pay because they don't want to, they don't pay because they actually can't afford to. I don't ever run into anybody who says I want to purposefully not pay my debts because even though I can. And I would actually kind of like to tie this discussion in with the piece just below this that was added in about going after an estate. So I hope everyone remembers the testimony of Nick during the original hearing. It was very compelling and moving about what his family went through. And adding this piece back in would actually ensure that Nick's family was not able to keep his home. We're talking about people here who are eligible for low cost or free care, reduced cost or free care, and going and potentially taking away the family home is something that is going to remove any ability for a family to do any sort of intergenerational wealth transfer and lift themselves out of poverty into the future. And it cuts that off at the knees. And so those are the comments that I wanted to make about this.
Thank you. Manzi.
Thank you, Delegate. I think on this piece around the thresholds, again, want to note that this is an option that, or a tool that's used by hospitals kind of as a last resort. Again, we've worked through the financial assistance process. We've worked through sending bills and notifications and trying to put individuals on payment plans. And then we have this piece about legal action. I will note, as members saw in the testimony, both by the HSCRC, who I know has joined us today, and also from the Maryland Department of Health, that any changes in this space on creating thresholds would undoubtedly impact uncompensated care. And so you've heard us say it, but you've also heard the state agencies make that mention as well. For that uncompensated care to increase would impact Medicaid state funding too, and that's why the Department of Health provided their testimony here. The study that was cited earlier about the $7,000 impact, I think our estimates show that it's significantly more in that space, hundreds of millions of dollars that could be impacted here, particularly when we look at the impact on uncompensated care as well. And so I just want to make that point again, that in addition to the fact that we try to use every tool in the toolbox, but we do need this to exist still in some form, that it would have an impact on uncompensated care. And that's been stated by more objectively by those other agencies.
Okay, thank you, Muzzy. Delegate Kipke, do you need to add something new, or can we move to the next item?
I will go along with whatever you'd like, Delegate Collison.
Okay. I think we've heard clearly both sides of the concern around lines 21 and 22 on page 8. We just heard reference to lines 23 and 24. Some concern there. Are there any other concerns on page 8? Okay. Oops. Delegate Saab, is your hand still up? Yes. Delegate Saab?
No, I'm sorry. I never put it down from before. Thank you.
Okay, great. Thank you. Let's go to page 9. Issues on concerns on page 9. Megan Renfrew.
Yeah.
CRC, our champion.
Buddy. So our concern on page 9 is on lines 23 through 24, which states that the simplified language would be as determined by the regulations. This differs from very similar notice requirements that are in Health General 19.214.1, which is the financial assistance section of the statute. And we just wanted to suggest that perhaps we could make those two parallel. So there's no regulations in this specific language, but there's a more general set of policies that the commission has to come up with.
Does it change substantially any of the intent here?
It doesn't change any of the content. It just means we're not writing the notice. Instead, we're putting out general requirements to the hospital about the notices as a whole.
Okay.
Yeah.
So then it's really just about referencing that section of the code that HSC.
We could do it that way. Yeah. I can send you a couple. I can send you an options.
Okay, great. Thanks. Anything else on page 9? Okay. Bridge.
Delegate, I just wanted to share as well that because hospitals are getting charity care funding, and a lot of that does come from taxpayers, I believe that it is an abuse of taxpayer funds to receive charity care funding and turn around and sue patients who are supposed to be getting free and reduced cost care. I, of course, fully support charity care funding. I think that's a fantastic program. I just want folks to think about that point as well, that there really is some double dipping happening here. And also second all the points about the need for a cap on lawsuits at $1,000 or less. Thank you, Delegate.
Does anyone from the hospital want to speak to that? Brett?
Yeah, with respect to that, appreciate the comment on that. We have to keep in mind that our system, our Maryland system, yes, does provide charity care and rates. And one of the reasons that the system works is, again, we want to provide charity care to anyone who cannot afford to pay very clearly, and we absolutely do that every single day. Part of that is to keep the amounts that we include in hospital bills for charity care low, again, is to collect on the outstanding balances that we're owed. So this isn't a question of double dipping to provide charity care. This is a question of maintaining the charity care funding in rates. There's no special funding for charity care. This is not a double dip on taxpayer dollars here. Charity care is funded in rates. That's one of the hallmarks and the cornerstones of our system. And part of that is to keep those rates low, is the fact that when there are outstanding balances that we do collect on those.
Thank you. Okay, we're moving to page 10. Issues, concerns on page 10. Delegate Lewis Young.
Thank you, Madam Chair. I have a question as to why line 7 was eliminated and then 12 through 18.
Okay, 7 was eliminated because the primary dispute agencies are the Attorney General's office, and that would be the office who could provide the greatest number of resources to an individual. So rather than have the hospital maintain the list of available nonprofit government resources, if they direct them to the Attorney General, then they would have the greatest list and access to the greatest list of resources. And then you asked about 12, you asked about what?
12 through 18.
So this, once you've said you're going to provide the explanation of the financial assistance policy, that's the hospital's responsibility. The state policy is, again, going to be provided by the agency that they're appealing to, including MIA or HEAU. So this is keeping it within the context of the hospital.
Thank you.
Other questions? Oh, Jennifer.
Thank you, Madam Chair, and appreciate your response. I think that's right. I just want to emphasize, I think when we were looking at this language as well, just to go back to Pat O'Connor's comments earlier, that we want to make sure that we're providing the right information to patients and families in terms of their ability to appeal in a process or submit a grievance. And in other disclosures that this committee has opined about and other laws, we are very specific about referring individuals to the Health Education Advocacy Unit and the Maryland Insurance Administration. So I think we just really want to be consistent in that messaging. I think the other area, you spoke to it correctly, and MIA, I know this was in their testimony and you have representatives here today, but I think they just wanted some distinction that they don't determine the financial assistance for individuals, but they do handle any grievances or complaints as it relates to the carrier's plan on coverage. And so I think that might have been also some comments and feedback that was received by MIA.
Okay.
Madam Chair, while we're on page 10, in line 21, could we try to find a word other than practicable? It's very undefined. It's very subjective.
Well,
Delegate Collison, if I may, just briefly, I think
Sure.
that language was included because that aligns with the language that you all included in the financial assistance legislation last year, and it is defined in regulation by HSCRC.
Right, it's in previous
Okay.
legislation.
Thank
Thanks.
you.
Ashley Black.
I'll just add a me too to Delegate Lewis Young's point. I know that our concern was that under federal law, Section 1557 of the Affordable Care Act, the hospitals are already required to provide vital information in the patient's preferred language. And we had a concern that to the extent practicable conflicts with that. Definitely believe that a financial assistance policy would be considered vital information, considering that it could change the patient's financial obligation to the hospital. Thank you.
Thank you. It is 9:45 and the bells are going to be ringing here at the House Office building shortly. I think we've made good progress. We've had a really rich discussion today. I appreciate your patience and your participation. We have another meeting scheduled tomorrow morning at 8:30. We'll finish the last few pages and hopefully come back with some suggestions on in the areas that have been raised as a concern. So with that, we're going to conclude this subcommittee meeting today, and we will see you bright and early tomorrow morning. Thank you all very much.
There's another Zoom link for tomorrow morning that I will get to everyone.
Okay, thank you, Erin.
Yep.
Thank you.
Delegate Collison.
Thank you. Thanks for
Thank you.